And we are live, Senators.
All right, so this is Senate Health and Welfare. We're back. We're on H414, looking at an unused drug repository for Vermont. And we have with us Brendan Atwood from the Department of Health. And Brendan, why don't you come up, and then we'll hear from Devin Green of Vermont Hospital Association. And then we'll make a decision about how to proceed with the bill. Okay, thank you.
Thank you, Madam Chair. Good morning, committee members. For the record, my name is Brendan Atwood. I am a public health policy advisor at the Department of Health. Very pleased to be with you all today to discuss the proposal to establish an unused drug repository program here in Vermont. If it's helpful, Madam Chair, I just provide a very high-level overview of what an unused drug repository program is, a few thoughts on the language in the bill, and then answer any questions that you may have.
Yeah.
So,
And will you get us some written testimony?
Sure, I'm happy to do that.
Great.
Yeah. So the purpose of an unused drug repository program is to get drugs, medicine into the hands of the people who need it. And the way that this is done is that an unused drug repository program collects unused medication that would otherwise be discarded from both institutions like hospitals and long-term care facilities, as well as from individuals. That medicine is then inspected by pharmacists to ensure that it is safe, to ensure that it has not been tampered with, has not expired, and is not a controlled substance. And then patients can access that medication by working with a participating provider or pharmacist. As in 2018, when the department provided its last report, there remains a strong consensus among stakeholders in support of establishing an unused drug repository program here in Vermont, given the significant health, economic, and environmental benefits associated with these programs. In terms of health benefits, we would expect thousands of Vermonters to gain access to medication that they need, but either cannot afford currently or struggle to afford. And of course, with that, would see a positive impact on their health outcomes and their quality of life. The economic benefits fall into a few buckets. First and foremost, we would expect millions of dollars of medicine to be saved and given to people who need it. Nationally, unused drug repository programs have seen return on investments of 8 to 1. And the projections that we saw, that we received from 2 organizations that administer these programs in other states range between $3.5 to $7 million annually. And I think it's important to note that that figure only reflects the value of the medication itself and does not account for any additional benefits that would accrue from having, for example, a healthier workforce. We would also expect to see downward pressure on healthcare costs associated with this program. And then finally, institutions that currently pay to have this medicine discarded would see some cost savings as well. In terms of the environmental benefits, those are derived from the fact that all of this medicine, likely measured in tons, would no longer be entered into the waste stream. With regards to this bill specifically, the department.
Why would they discard medications?
So currently, prescription medicine has to be discarded under Vermont regulations if it's not used by that patient. So this would allow an opportunity for that medicine to be saved. The department is supportive of the language in this bill, which provides the Agency of Human Services with the authority to contract for and regulate the work of an unused drug repository program. Ideally, we would find a nonprofit organization with the infrastructure in place to administer this program. And the reasons for that are twofold. First and foremost, it would save on administrative costs for things like a warehouse and an IT system. But perhaps more importantly, it would avail Vermonters to a much greater supply, both in terms of type and quantity of medications than if Vermont were the only donor state available.
Would it be an existing nonprofit, or would we have to form this nonprofit?
Very good question. So the department's aware of at least 2 organizations who are in a position to be able to provide this service. So we would, of course, do an RFP and look to see if there were others as well. But we're aware of 2, the folks who administer the Iowa program and one in Georgia who would be able to administer this program. So we think that we'd be able to hit the ground running.
Okay. Would they need a physical structure in Vermont, or?
Not in Vermont, no.
Okay.
They have their own warehouse spaces. So, they would have some boots in the ground here to do outreach to get folks enrolled in this program, and we would assist with that as well. So I don't know if they would choose to have some space here, but they would not necessarily need it.
Okay, great.
Yeah.
How would they not need space here if a hospital or an individual is donating
So
medication? Where does it go from there?
So I believe both, certainly Georgia has a mailing system where they would provide all of the,
So we would mail the drugs to Georgia and then they would get mailed back to Vermont to be used by Vermonters?
correct,
Makes
but
sense.
well, so it goes into a centralized repository, which has drugs from Georgia, really from all over the country. Lots of states can donate into these systems. And so that repository has medicine from, across the country. And then that would, having that central repository allows us to take advantage of their pharmacists that they have on site already, their inspection protocols. And then, yes, it gets sent back out to Vermonters who need it. But whether or not that originally sourced from Vermont,
I see.
it is, not that doesn't necessarily have to be the case.
Got it. Okay.
So that's really it in terms of my testimony, but I'm happy to get into any other questions. I know, Senator, you asked last week about the safety, and hopefully that's been addressed here with regards to the pharmacists who would inspect this medicine. There were some questions about capacity, and again, that's part of the reason why we would look to contract for this. Getting Senator Weeks, if you also had a question related to this as well.
No, but I have a new one.
Yeah.
No, go right ahead.
So as my colleagues are kind of peeling this back, so you've gotten to the point now where you've outlined how the drugs go into a central repository, wherever that might be, but most likely outside the state, gets processed. How does it come back and who does it come back to?
Great question. So, and I should note too, that what this bill will allow the department to do is create rules to administer this program. So a lot of these details will get ironed out with stakeholders during that.
Yeah, just notionally. I mean, it doesn't need to be anything that we're going to.
Yeah, so patients would work with, so a provider, a healthcare provider or a pharmacist would enroll with this program, which is free to do. And then a patient could visit that provider or pharmacist to get access to this medicine.
So how does,
So the pharmacist, the provider, for example, would write a prescription. The way they would write any prescription, it would just be sourced from this repository as opposed to, say,
random,
local.
is it kind of random, or is it, again, I know maybe based on other states' experiences, but is it, say you're Medicaid or Medicare, or you're just, Joe Citizen, and who gets priority, and
It's a great question. So the legislation outlines some parameters for prioritization. This program is intended primarily to address folks who cannot access this medication because of financial reasons. However, what we've heard from the folks who administer these programs is that they have an oversupply. The demand is not the issue, and that they would not want to preclude folks who might also benefit from this program from having access to that, provided, of course, that folks who really need it financially have the prioritization there. And so we will determine in rulemaking how to define things like underinsured, but I think there's 5 criteria or so that relate to essentially financial abilities to pay for this medicine.
very good.
I just want to say, it sounds like a great thing to me. I mean,
It's been
Yeah,
sounding
well,
great for a long time.
Yeah.
And now we just destroy it. At best, we destroy it.
right.
At worst, it goes into the waste stream.
Yeah, I know.
For
Shows
the
up in
environment.
Lake Champlain.
Right.
Did you have some comments you wanted to make to any specific sections of the bill, or?
No,
Fine with
we're
the bill the way
supportive.
it-
Yeah, we're supportive of all the language in there. We worked with Vaz and Jen after hearing the House to add some liability protections, which the department supported. We included that in our report to the legislature as well. And so, yeah, I think we're very comfortable with all the language in there.
Okay. Cool. Good.
Do you want a motion, Madam Chair?
I am
Or are we not?
probably getting to that, but
Yeah.
I think we'll
Exciting.
let Brendan sit over there, so he doesn't have to.
Thank
feel
you.
compelled,
Be in
and
the
we'll
hot
bring
seat.
Jen up very briefly, if there's anything here we need to look at with Jen. Jennifer.
I think she's in the zone.
Oh, you want me now?
Yeah.
She was in the zone.
Sorry.
I mean, when I get, this is just what happens to all of us.
You
We
were
get-
focused.
we just need you here for reassurance. We have the bill in front of us, and we haven't made any changes to the bill. So this would be a vote, if we have a motion, it would be a motion to concur with the House proposal on H 414.
Yes, for the record, Jen Kirby, legislative council. Yes.
Michael Fisher is on the screen.
Yes, I know you have.
And he's here. And Michael, did you want to add a comment before we dive ahead of you? Thank you for being here.
Thank you, Mike Fisher, healthcare advocate. Yeah, I'm happy to. Can you hear me?
Yes, we can hear you.
You're frozen.
You're frozen.
Kill his video.
Maybe you should.
Turn your video off a little, I
Okay.
think.
I will attempt to do that.
But you're smiling.
The volume is
It's
good.
a nice frozen shot.
Yeah, it could be worse. It could be worse.
Let me check again. Can you hear me?
Yes.
Yeah.
Yes, I think the Healthcare Advocate's Office can be, is broadly supportive of the bill and the effort. And yes, we've been talking about it for many years and continue to think it makes sense. I think that I just want to call out a few issues that I want to recognize and support a concept that's in the report provided by the Department of Health about the funding source, that the cost to people accessing these meds should be very low, if at all. I would sort of recognize the state's the availability of VFARM medications as a possible model of not going higher than those kinds of copays. And that is an issue that the legislature will have to deal with next year, or when you're ready to implement this in terms of the funding of the program. I also want to say that it's going to be something of an effort to make sure people know about it and that the provider community knows about it. And so, again, this is a preview of comments for next year. It's going to be important to fund it so that it can really work. And then lastly, I did want to say that I hope that we will engage with the Department of Health on the rulemaking process. I think the definition, there was some discussion last week about the definition of underinsured. We think that the definition as that the Household Health Insurance Survey, this is the Commonwealth Funds approach, is a good one. And it recognizes that this concept of underinsured is complicated. It is indeed people who have very low value plans and low income and health insurance costs. But it is also people with relatively rich plans and relatively low income and a lot of healthcare costs. And so the Commonwealth Fund, the state's household health insurance survey addresses both of those dynamics. And we hope that when the department addresses this, they have a similar approach. And then my last comment, last comment.
Just before you give your last comment, you've said a lot. And I think what we need from you is something in writing to have accessible. But go ahead. With your last comment.
Lastly, I'm not suggesting any change in the bill in front of you. I think you're ready to move on it and we support that. Okay. But I do want to say out loud that one concept that is not spelled out in the bill that we think is important to spell out in the rules is how this program will wrap around existing programs. I don't think we would want to make these medications available to people who are on VFARM, for instance. And so that's just another detail that I think will make sense to spell out in the rulemaking process.
I think VFARM. That's what. Oh, VFARM. Yeah, Jen can explain what that is.
Okay, so thank you. And what we're hearing you say is the bill is written, is fine from your perspective. And
that's correct.
So in anticipation of a vote today, that's very helpful. Thank you.
Yes.
All right, we're good. All right, committee discussion. And so good, go ahead.
Can you explain the Commonwealth bond concept?
He's just talking about the Commonwealth Fund, which
Fund,
is an
okay.
organization, and they do a bunch of work in the healthcare space and have a definition of underinsured.
Any other questions? Oh, yes.
Super quick. It's Devin Green, Vermont Association of Hospitals and Health Systems, and I'm not just here for myself. I'm also here for the Vermont Healthcare Association, the Vermont Medical Society, Bi-State Primary Care Association, and the VNAs of Vermont.
Yes.
And we all heartily support this.
We like that.
Yay.
After 171 is the best pressure.
Full palate cleanser.
That's why I'm like, let's.
I know, right? Let's do it.
Yeah,
One more question. I've got, let's say I go to a dentist and I have to take amoxicillin before I go for cleaning and that. Typically, that prescription will be around for a year. But in anticipation of having to go to my next doctor's visit, I'll have the prescription renewed. And a lot of people that are conservative will throw the old prescription in with the new. Is there a way to test individual pills, or they just look at the bottle?
So in that case, most of the regulations that we've looked at, and where we're likely headed with the rules as well, restrict medicine that has been opened. And so really what we're looking for is medicine that's in an unopened original packaging from the manufacturer. There are exceptions to that for facilities like hospitals that might have more stringent regulations to ensure that their bulk bottles have been, stored and kept in an appropriate way. But for individuals, my presumption is that the rulemaking probably disallow that type of donation.
Okay.
good questions. Yeah, it would be great if we could go into everybody's medicine cabinet.
Right.
So, yeah, and it's, so this is great. I'm looking
Did
for
Senator
a
Hardy already make a motion?
proposal of
I will make a motion to approve at, what number is the bill?
H414.
H 414 as proposed by the House
Very good, send it to full Senate.
and
Yeah.
send it to full Senate.
Second.
Or-
All right, okay.
Okay, I think we're ready for a vote on H 414. And seem to always be the first one to vote. Senator Gulick is a yes. Senator Hardy,
Yes.
Senator Williams.
Yes.
Vice Chair Weeks.
Yes.
And Chair Lyons.
Yes.
Wonderful. Vote is 5-0-0 in committee. And who will report?
Oh, who would like to report? But I'm looking at Senator, somebody.
Senator somebody.
I mean,
Okay, we're all raising your hand.
Terry, you want to do it? You do it. All right.
Oh, good. That's good. All right. But I like spread. This is a fun one. You get all the good ones.
Yeah, this is a good
This
one.
is not
Hey,
fair.
I'm a rookie.
Yeah, okay. That's great. There is one more thing. Thank you, Michael, for being available, and thank you, Department of Health, Brendan.
Thank you all very much.
Yeah.
One second.
There is
You
another
too.
issue that I'm hoping we can look at this morning before we end at 11:30, and that is that S36 has come back to us from the House. It went to the judiciary. It's the violence in healthcare facilities bill. It was really in judiciary, but we also put an amendment onto it. And I've looked through it. There's a lot there. And I think, Devin, you're here, that's me.
I'm here for both.
What bill is this? I'm sorry.
S36, the healthcare violence bill.
Oh.
And so I've asked,
I'm not sure if he'll be able to join us. I've reached out to him, but he is in House Judiciary.
it's Eric.
It's Eric.
Yeah, Eric is the one who was gonna walk us through the bill. So what we'll do is we'll try to take a look at it with Devin, because you're here and you're experienced with the bill. And then we'll bring Eric Fitzpatrick in tomorrow morning. Come in, please. Awesome. I looked at it myself, but there is a lot there. There are a number of changes. The Senate Judiciary has approved that section of the bill relating to them, including a word that I'm not familiar, but it is, it's tumultuous. I'm not familiar with that. Okay. Tumultuous. Devin, do you mind coming up and sharing what you know about what's in the bill? I know that you're an advocate, you're not our ledge counsel, but you've been following the bill right along, and it would be helpful just to tee it up a little bit, and then tomorrow we'll go through with our ledge counsel.
Sure, that sounds great.
And it's on the notice calendar.
Okay.
We can go to it on our notice calendar. You have it,
Gonna pull it up.
share. Can you give her share,
Yes, I can.
or you share?
I don't have the Zoom.
I can send it to you.
This is how things happen at the end of this session.
I'm desperately trying. to
And it
keep
has
tabs
been
right
on
now.
notice, but, and I went through all the notices and saw it there finally, so.
I'm working on posting it to the website right now.
Might go along this way.
It's on page 1959 of today's calendar. And you can just click on that.
And that is the one that was passed by the House, or does that have the judiciary?
Passed by the House. House proposal of amendment, S36, and it's on today's calendar, and Alex, you're posting it.
I am.
Why don't you post it, why don't you put it up on the screen
Okay.
and for us?
Okay, so Devin Green, Vermont Association of Hospitals and Health Systems. And I will say that I am doing this a little bit on the fly, so
We understand.
if I have
We
any,
won't
I will
over
come back with you with any issues, but we do support the House version. We appreciate all the work that both the Senate and the House have done on this bill. We appreciate your addition of the criminal threat piece that adds healthcare workers to that, and that has remained unchanged from the House version, but
So what I'm hearing you say is the work that we did hasn't been changed for that.
correct. I would say that the only change in the work that you did. Okay, well, I'll just walk through the bill. So, okay. So the first piece that was changed was, this has been narrowed down from healthcare worker in a healthcare facility to healthcare workers in hospitals and EMS workers. So there were concerns from the Alzheimer's associations and other advocates about this being used too broadly. And a lot of the testimony was from healthcare providers in hospitals. So I think that can always be up for discussion about should this go to other places, but I think in terms of the immediate need, hospitals and EMS workers are in the most immediate need right now for this. And then the other piece that was changed was in this Rule 3 part, which if you remember, it allows for warrantless arrest of individuals who have committed simple assault, criminal threatening, and disorderly conduct. The piece that has been changed there was you narrowed disorderly conduct to A1, the part that included fighting, threatening, and tumultuous behavior. And the House has eliminated tumultuous from that definition.
And I understand that the Senate Judiciary Committee is putting tumultuous back in.
Oh.
That is what they
They're
discussed.
discussing it.
They're
Okay.
discussing it. I
Okay.
think their concern is around creating a precedent of changing the definition of this piece of, like, I think there's one thing to limiting the definition to disorderly conduct to something that's already there, but changing it from what it exists to something different
But we didn't, right?
is a, they are worried about that precedent.
Okay.
We support either version without tumultuous or with tumultuous.
Okay. That's helpful.
It's only if it's a the.
Nothing
Sorry.
We like it,
I have to
guys.
get the little ticket.
And then, the criminal threatening piece remains the same.
Okay.
And so that stays the same from where you had it. I think, emergency medical personnel is spelled out. And then the other piece is on, I guess, starts on page 5, where we get into what we were doing with HIPAA. And so what we had heard from law enforcement and from hospitals was that law enforcement will come and HIPAA precludes hospitals from saying something like, this person is discharged, they're stable, you can remove them. This requires hospitals to tell law enforcement the health status so that law enforcement doesn't have to worry about liability. And then added on to this is clarification about EMTALA and when a person can be removed from a hospital and when they can, or an emergency scene, and when they cannot be removed. So if they're not stabilized, which is already required by federal law, they can't be removed from the hospital if they have not been evaluated yet, or if they're awaiting inpatient transport for care, that sort of situation. So they need to be hospitalized, then you don't remove that person from the hospital. Or in the case of EMS, the scene of the emergency. And then there's section 4 on page 7. We have expanded the report on de-escalation. It is more than just a report on de-escalation. This was actually taking some components of a House bill and putting it in here, which would have reporting done on de-escalation, staffing levels, ongoing assessment of visitors, and patients for aggressive behavior, indicators to adapt care interventions and environments appropriately, centralized reporting, and factors relating to the physical environment. So all of this is to look at this more broadly, look for the resources that are in place already, what resources do these organizations need, and an emphasis on we need to look at this through an equity lens. Because I know there are concerns about equity and how certain populations are treated here as well. Within all of this, we are committed to collecting and reporting demographic information on our end. Because in the next section, section 5, you'll see that DPS has come back and said that the way we have set things out, they're not really set up to collect data this way, but they're going to come back on how they can collect this data. So in the time being, we will collect data from our end, and then DPS will come back with how they can collect data.
Good. Yeah, we actually heard from the Department of Public Safety, from Jen Morrison, about that their ability, they would do that. And we're glad that you're doing it. Okay, good. Thank you for being here and for helping us out. This gives us a quick look at what's there, and
Can I ask a
doesn't
quick
sound
question? Sorry.
significant, but
Sorry.
yeah, go ahead.
And I think Senator Hardy, this was your ask a while back about the data collection. Just to clarify, this is to gather data to inform future policy action, potential changes to this bill.
I think it's gathering data to inform how this is being applied and how we should be doing our practices. If we do see that certain populations are being impacted disproportionately, we want to take a look at that and respond. So we want this data, and then also future policy as well.
Okay, great, thank
It's
you.
part of the whole health equity issue that we've been focused on since the pandemic.
Yeah.
Before.
Great, thanks.
So good, and we'll have Eric Fitzpatrick come in. Is he available tomorrow morning?
He should be.
At what time?
His calendar looks pretty open.
Oh, good. I'm wondering,
Okay.
I'm wondering if with due thought to the committee and how busy we all are, but if we met at 8:30 and took this up tomorrow morning, we have a number of other things that are less simple.
That's not, I don't think that's gonna work for me, but
It's not,
We have a
we can start at 9.
yeah.
We'll start at
Maybe
9.
we
We're
can
on the floor and we'll try to put this one on right away so that we can
Yeah,
report it on the floor. I'm thinking that judiciary will be done with it as well. If they're not, we'll just hold it.
maybe we can just be really efficient with our time.
Huh?
Maybe we can just be really efficient with our time and get
We
everything
are
done.
doing-
What if?
We're doing
We have a limited amount of time with Katie and all of the.
it. Okay, so we won't put it on at 9. We'll just we'll put Eric on later. We don't have
We don't have
414 on anymore, so we'll just put it right there.
That's why I was like, let's just vote this today.
I know,
No, we
right?
can, but I'm.
No, no,
I'm
four
not gonna
fourteen,
do
no,
that
I meant the
yet.
drug depository,
We
not
did
this
it.
one, not this one.
Yeah,
Yeah, I
we did
know,
it.
I know we did, that's why I said, that's why I made that
Yay,
motion.
we're
so we could take it off our
happy.
agenda.
Bravo.
We voted everything except 171 and 481. So those two bills are less, well, 171 is not without complexity. 481 is, okay. So that's it. We can go
Do
offline.
we want to talk about nominations? Or-
No,
Do you
tomorrow.
want to do that now?
No, I don't want to dig into it and then have to,
Got it. You review it.
I'm ready for tomorrow.
You are, okay. We'll